in University Hospital.
Yes. مساء الخير, السلام عليكم. I'd like to thank the organizers, Professor Hisham Al-Ghazali and his co-organizers, Professor Hisham, Professor Ahmed and Yahya for their efforts and inviting me. It's always great to be back in Egypt among friends. Now we'll switch gears back and take you back to younger generation and their challenges. My talk outline would be along the following. First, let's focus on why are we discussing this issue? Is it worth all this effort? Let's see. Worldwide, breast cancer ranks second only to lung cancer, accounting for about 11% of cases. In our region, in the Middle East and North Africa, it ranks number one, accounting for 15% of new cases diagnosed annually. Not only that, about 1/3 of cases are diagnosed in their 40s, and this is not only in one country, in most of the surrounding countries. So the median age we see is about 50 years. This is 10 years younger than what we see in the Western world. Let's take Jordan as an example, since I have accurate statistics. About 50% of patients are diagnosed at age 50, at age younger than 50, with 1/3 of the cases diagnosed at age younger than 45. 1/3 of the cases. This is 3 times what you see in the highest statistics in Western countries. So we are bound to face these problems, even if we try to ignore them. 3 times what you see in all other parts of the world. The problem is even compounded by the fact that women tend to delay childbirth. This is not only actually in Western countries. I do not have accurate statistics from our region, but this is the fact worldwide. So this number is bound to increase and probably double in the next 10 years. So when we treat women at young age, the balance is always, and the challenge is to maintain this balance between tumor control and quality of life. That's the goal whenever you're treating any disease. When you are treating a young patient, the problem of fertility or the challenge of fertility comes into play. Not only because of the effect of treatment, be it chemotherapy or biologic treatment or hormonal therapy, it's a direct effect, but also there is the indirect effect of the time factor and its impact on natural physiology. So we are tackling the subject from 2 different perspectives. And that has to be kept in mind whenever you are dealing with a young patient. For some reason, the animation for my slides is not coming correct, so excuse me for that. Before we discuss the subject further, we need to remember the normal physiology. Ovarian reserve is age-dependent. The number of non-growing primordial follicles in each ovary decreases with age. That's the natural physiology. However, it's individual-based, and you cannot predict that curve to be accurate for each patient. Genetics and lifestyle come into play. So ovarian reserve is a factor that reflects fertility, and the word fertility for us all is reflected in 2 pictures: menstrual function and pregnancy. We always think of these as redundant, same terminology. However, they are not the same. Having regular menstrual function does not guarantee that the woman is able to get pregnant. And that's why sometimes a woman still has her regular menses after getting treatment and cannot get pregnant. The impact of treatment is directly affecting the number of growing follicles and indirectly affecting their environment. The environment could be unhealthy because of vascular injury and cortical fibrosis of the ovaries. So the impact of treatment could result in either acute ovarian failure and complete infertility, or premature menopause with a woman having regular menstrual function but not really able to get pregnant. So this is the theory. How about the clinical facts? We know that getting treatment would result in amenorrhea in a range of 10% up to 75% among the women treated. And among the most commonly used regimens for cycles of anthracyclines, that is about 1/3. With the 8 cycles of sequential treatment, again, commonly used, it goes up to 70%, it doubles. Interestingly enough, the same regimen, when given to women younger than age 40, that is only 15%. And I will take, this is the NSABP trial, one of the most recently completed adjuvant trials, one of the largest, and using modern regimens we use in everyday practice, rather than quoting older regimens and older data. It used the sequential 8 cycles of anthracycline and taxane, comparing them to 4 cycles of concurrent anthracycline taxane without alkylating agent, compared them to the famous TAC regimen, 6 cycles. More than 5,000 patients were randomized. In that particular trial, as you can see, the rate of amenorrhea among women aged younger than 40 was different among different regimens, least being among women treated, let's see if I could show you, among women treated with non-alkylating based regimen, the yellow line. Highest among women receiving the highest number of regimens, of cycles, the 8 cycles for anthracycline, for taxane. Same fact for women older than 40. The non-alkylating based regimen was associated with the least rate of amenorrhea. So the rate of amenorrhea is age dependent and type dependent. From that trial, we learned that overall survival was best achieved using the 8 cycle sequential regimen, a borderline significance, particularly against the 4 cycles of concurrent treatment without alkylating agent, anthracycline taxane. The disease-free survival was significantly in favor of the sequential regimen as opposed to the concurrent 6 cycles of TAC as opposed to 4 cycles. However, as you can see, the differences are marginal. Maybe we need to inform our patients about these facts and help them decide what adjuvant treatment they would like to have. You would think that's not fair. Women would go for the best overall survival. However, that's not really true. This is a retrospective survey of more than 1,000 women who were treated for early breast cancer. Their median age was 33 years at time of diagnosis. At time of survey, 2 years later, they were about 36 years old. 2/3 were married. The stage of a diagnosis was variable for those women, and only 3/4 of those had the chance to discuss fertility before making the decision for their adjuvant treatment. Despite this, you would notice that 30% of those women, when making the decision for their adjuvant treatment, actually took into consideration fertility. And it did impact their decision for adjuvant treatment. 30%. And those were mostly the women who are concerned about fertility when they started treatment. So women have the right to be informed before making a treatment plan. And the dose of treatment used actually does impact the rate of amenorrhea and fertility. The higher the alkylating agent you are using, the more likely the woman would be permanently amenorrheic. So it would affect your choice of regimen to decrease the number of cycles when the alkylating agent is received. How about hormonal treatment? The LHRH analogs, they induce reversible amenorrhea. However, again, it is age dependent. So you do expect about 30% of permanent amenorrhea if you start a woman older than age 40 on combined hormonal blockade. How about tamoxifen? Again, a similar trend is seen with age. You're expecting the rate of amenorrhea after chemotherapy to be increased by 10%, actually independent of age, whenever you are using tamoxifen. And again, I'm going back to the NSABP trial. You can see the interrupted line for each regimen, followed by the solid line showing you the increase in the rate of amenorrhea when tamoxifen was added to the chemotherapy adjuvant regimen used, independent of the time of chemotherapy, of the type of chemotherapy you are using. How about biologics? We do not have enough data. However, I could tell you the leaflet for bevacizumab has a note that it does increase the rate of ovarian failure. That note was actually added after data from the adjuvant colon trial that failed to improve overall survival. Probably this is where the data came from, because most of the time we're using it in breast cancer and metastatic patients, and the data came from the colon cancer patients. How about trastuzumab? That's more important. We use it a lot, especially for our young patients. The good news, probably it does not increase the rate of amenorrhea. This is retrospective data from more than 450 patients who were treated with trastuzumab adjuvant-based approach, median age 42, with a good, reasonable follow-up of about 3 years. What's good is that whether trastuzumab was included in the regimen, in the adjuvant regimen, there was no increase in the rate of amenorrhea. Again, more interesting is the schedule did not impact the rate of amenorrhea. So if treatment was delivered every 2 weeks as opposed to every 3 weeks, there is no increase in the rate of amenorrhea. We keep talking about amenorrhea. What do we mean by that? In fact, the definition is quite redundant. However, cessation of menses could be reversible, and you cannot declare your patient amenorrheic even after a year. However, most patients of those who would have reversible amenorrhea would have their menses resume within a year, an average of 6 to 9 months, independent of age, independent of the regimen used. As you can see, this is a study looking at most series reporting amenorrhea and the timing, and what they found is that from most studies, this is the average time when a woman would regain her menses. However, even if the woman gains back her menstrual function, that does not guarantee ability to pregnancy. Reproductive ability can be measured directly by antral follicular count, the number of primordial follicles in an ovary, or indirectly through hormonal measurements. If you look at either, you would see that there is a significant difference between women who still have their period after their chemotherapy as opposed to those who had never received chemotherapy. That's true for both the direct count and both for hormonal measures. And the most sensitive of those is the anti-Mullerian hormone, and you can see there is a significant difference showing compromise in the ability to get pregnant in women who regain their menstrual function after treatment. So, menstrual function does not equal ability to get pregnant. So what's the challenge we face as physicians? To reassure everybody in the audience, we're not the only ones among physicians to be challenged by the ability to counsel our patients about pregnancy. This is a study looking at physicians from different subspecialties and how many of them counsel their patients about infertility or menopause or other adverse effects of treatment. All physicians do talk about adverse effects. However, only 2/3 would discuss menopause and only 1/3 would discuss fertility. And I'm not talking about oncology, rheumatology, surgery. The best part is that despite that we are not doing great, medical oncologists are the best, and still only 60% would counsel about menopause, 1/3 would counsel about fertility. So why is that? To be honest, before I was asked first to discuss this subject, this is one of the most annoying topics that comes to my mind whenever I see a young patient. And I personally try to avoid it. I don't think I'm the only one in the audience. Most of us do the same. It's a challenge. Think about it. You see a young patient, she has a locally advanced disease, she has inflammatory breast cancer. You want to counsel her about infertility or her options to maintain her fertility. She has to go for some form of ovarian stimulation, for oocyte preservation or embryo preservation or whatever. That takes time. It takes an average of 6 to 8 weeks. How am I going to talk to her, tell her, okay, you have options, but that would compromise your ability to survive? So I'd rather not bring it up if she doesn't bring it up. And another challenge, if she's single, that's even worse. Remember, there are social and cultural and religious restraints to what you could help or do to help your patients. That they differ from a site to another, but I'm sure they are quite common in our society. and they're not easy to discuss. Even worse, if a woman has a stage 4 disease, you're still breaking the news for her. You're going to tell her, okay, you have options, but your chance of surviving long-term probably is less than 10%. To be realistic, it's not easy. Again, for those of us who are working in institutions, they have time limit, and they're seeing so many patients, and this is a subject that takes time to discuss with your patients properly. And there is the inherent physician beliefs. I'm not sure how did Hatem, actually we should have a vote after Hatem presentation, who would believe pregnancy after breast cancer is safe and who is not. Despite the evidence supporting the safety, every physician has his own bias. That's the reality. And it would have been great to have a vote from us audience after this session. Some of us, even if they believe in that, you need a special facility to facilitate, preserving fertility. And the safety of pregnancy has been tackled properly and thoroughly earlier. So I could skip this. This is a slide meant for you not to read. It's a list of all the trials that show you that amenorrhea significantly correlates with survival after treatment for breast cancer, independent of the treatment used. For women, of course, with ER-positive disease. And again, the NSAPP trial I just shared with you, in that same trial, disease-free survival and overall survival significantly improved among the women who were amenorrheic after treatment independent of the regimen used, with a 50% reduction in mortality for women who have ER-positive disease. Just think about the facts. Add to this body of evidence the recent Atlas data talking about extended adjuvant hormonal treatment. How would you counsel your patients? You have a body of evidence supporting having a woman with amenorrhea after ER-positive disease. I think the only reassurance would come from the prospective trial Hatem just shared with you and from the SOL trial. If intermittent hormonal treatment is helpful and useful, I think it would give us reassurance, and the patients would give them reassurance to get pregnant and go back on their hormonal therapy. But until the results are available, I think it's very hard topic to decide upon, whether for physicians or for patients. What are the options? They should be tailored, again, to patient age, stage of disease, social status, financial status. Those have to be taken into consideration. The options available, and that slide should have been animated, unfortunately it's not, cryopreservation of ovarian tissue. That's actually very practical, short time to perform. It carries the risk that it's not always successful, it's actually experimental, available in only few centers around the world, and carries the possibility of tumor dissemination. You cannot guarantee absence of tumor cells from ovarian tissue. Still under study. How about cryopreservation of embryos or oocytes? Well, embryo is being used for a while in IVF and it's been successful, but the woman should have a partner. Could be an issue, maybe not an issue in Western countries or in some countries, but not in our part of the world, for a single one. In terms of oocyte preservation, it's getting better. However, there is a treatment delay, there is limited success, and it uses induction hormonal treatment. Is it safe? Could it result in tumor flare? The only data I found about safety comes from Turkey. Again, they did this study prospectively, looking at combined hormonal blockade, RH agonist to induce ovulation, and aromatase inhibitor to block their impact on the tumor. And they assessed the outcome. With a median follow-up of 2 years, there was no increase in relapse-free survival, but that's quite short for endocrine responsive disease. As you can see here, it's only 2 years median follow-up. How about the LHRH analogs? That's what we could do, especially as medical oncologists, and we have it handy. It makes sense because it will induce a quiescent state for the primordial follicles, protect them. Probably it would reduce vascular supply to the ovaries and protect them from the delivery of treatment. That's the theory. However, it would also protect the tumor probably from the impact of treatment. So what do we have? What evidence do we have? We have 5 retrospective trials and we have 8 prospective trials. Only 1 has not been reported. So again, this table is not meant for you to read. These are the 8 prospective trials. The problem with those, they have variable age of enrollment. Some patients were in their 30s, some in their 40s, some in their 20s. No data was reported with adequate follow-up for the disease outcome. And the endpoint for fertility preservation was most of the time cessation of menses, but there is no time defined. 1 year, 6 months, 2 years follow-up. 3 trials showed increase in the rate of maintenance of menses after chemotherapy. 4 failed to show a positive impact. And there is limited data in terms of pregnancy outcome. Only 1 trial of the positive trials showed ability of those women to get pregnant. So what can I say? I would say with 3 positive prospective trials, 4 negative trials, 5 retrospective data, the jury is still out. What can we conclude? I don't think I could leave you with one conclusion. Unfortunately, the slide doesn't show here. It has to be a mutual decision between the oncologist, the patient, and the reproductive oncologist or gynecologist to decide what to do considering all this data. And thank you for listening.
Thank you, for Professor Sana, for this elegant presentation. We have time for only one question.
Wow, I made it that clear. No questions.
So we have a question in the back.
Okay, thank you for the presentation. You said that there was we all know that there is a lot of evidence that extended hormonal treatment is beneficial. So I wonder why it's not standard for castration of young patients for 2 years. It has never reached standard evidence. What do you think of that?
Well, you do need for something to be standard of care, especially with the combined hormonal blockade. By the way, it is standard in my practice, and I know so many of my colleagues. I'll tell you why. Because everybody is waiting for the prospective data from the soft trial. We do not have prospective evidence. All the evidence you find for combined hormonal blockade is retrospective from trials. The only prospective data would come from the soft trial. That is still pending. Hopefully soon, within, I think, the next year or so, we will have the data. That trial prospectively compared tamoxifen or aromatase inhibitors versus combined hormonal blockade. If it tends to be positive, it will become standard of care.
So with this, I'd like to thank all the speakers for sharing important information and very special situations in breast cancer. I'd like to thank the co-chairman, and I'd like just to tell you that you need to be here back again at 1 for the hormonal treatment of breast cancer session. Yes, thank you. 1, I said 1.